my most challenging case of CTO. This is a case where every step actually created a problem, during the course of intervention. See, my patient is a 58-year-old male, old anterior MI with cardiogenic shock, for which he has undergone primary PCI with stent to LAD. That time itself, there was an RCA CTO, but not treated subsequently. He has moderate LV dysfunction and not in decompensation. So this patient came with exertional angina, progressively increasing despite optimal medical therapy, and stress nuclear scan showed clearly inducible ischemia in complete RCA territory. And this is after 2 years of primary PCI. And CAG done showed patent LAD stent and CTO in right coronary artery. These are the comorbids, and his renal function is something which is concerned about, subsequent intervention. And this was his ECG. Inferior is good, and you can see this is his echo showing good reason wall motion, and inferior it's in inferior wall, and in fact anterior wall is a bit hyperechoic, due to previous infarct. And this was the angiogram. You can see a patent stent in LAD, and you can in fact see right coronary artery is filling from left system retrogradely. So there is lesion in distal LCX, but vessel looks quite smaller. And this is a right coronary artery which is occluded from proximal. There is only very small area, and after that it is occluded. In fact, it is also originating from anterior part of the sinus. If you closely observe, it's not a regular origin of right coronary artery, and it's dominant. So you can see that's a length of the total occlusion. So in right coronary artery. So this is the anatomicogram of this patient. So there is a total occlusion, and there are septal collaterals coming from left anterior descending artery, and there is a stent in the donor vessel. And if you see JCTO score, it's a long length lesion, and there is a clear bend within the lesion. So it's a JCTO is 2, and entry point is very clear. So as entry point is clear and the distal vessel is clearly visible, so obviously my first strategy is antegrade approach. If it doesn't work out, then we'll go to retrograde as there is clear interventional collateral present. So, and these were the challenges which I anticipated. Proximal RCA CTO, the guide support is an issue, and we thought of taking AL guide with an anchor balloon support, and also stent in the donor vessel, which can create a problem. So that basically, you can do IVS after retrograde gear removal and address accordingly if there is any disaction. And this is a dual injection. You can see dual injection I'm giving through, antegrade injection is given through the microcatheter, since the total occlusion is almost sitting in the proximal RCA. That's one technique which can be used, and you will get good visualization. You can see a good long CTO with a good distal vessel. And once we started wiring, you can see this is a microcatheter injection. There are a lot of branches around CTO, so it's really difficult to decipher the course of the vessel here. Since we thought we'll try antegrade, so we took a Fielder XTR and tried loose tissue tracking, and this is what happened. So after that, we couldn't able to see the distal vessel so clearly because I was not able to inject through antegrade, as the guide is almost sitting into the RCA with the complete pressure damping. So we couldn't inject antegrade, but with retrograde injection, I couldn't see it very well. So that stops your antegrade wire escalation, poor guide support as well as poor visibility of distal target. So that's when I went to the next step, and we started surfing septals. Since there is a stent in the donor vessel, we decided to go with a septal which is beyond the stent. And this is what happened. That septal is connected to RV branch, you can clearly see the course of the wire, and you can in fact see how the wire is actually dancing in RV branch. So that makes, sending your microcatheter across a bit difficult. You can also see the angle in the course of the wire, so which is quite difficult to navigate with the microcatheter. So that's what happened. So I had to go with another septal. You can see this is RV branch. We just injected to make sure we have not done any damage. And I took next septal, which is through these shunt struts. You can clearly see here. But as I couldn't wire with a regular method, so I had to take a crusade only to enter septal collateral. So we entered septal collateral, and then we dilated with a 1 mm balloon, you can see here. And then we went into the first septal, and subsequently we crossed with the CO03 wire. So this is a CO03 with which I could able to cross with Corsair support. And once wire is in right coronary artery, you can see how the wire is moving, retrograde wire. So there is the bad bend within the distal RCA. So, and this is something you can see here in LAO and RAO, how bad the loop in the distal RCA is, and which is quite difficult to navigate with the Corsair Pro. So I tried advancing Corsair Pro, but I couldn't able to advance through that loop. So, and it becomes difficult to do a retrograde wire escalation with such a loop, because any stiff wire can go subintimal, and it's difficult to even reach distal cap. So at this stage, this was the next issue which I had. I tried marker wire, as I cannot escalate retrograde wire, but even marker wire didn't work because of the loops in the right coronary artery. That's pretty difficult even for marker wire. So this is what we did, but again failed. And then I decided to escalate retrograde wire to pilot, because this Gaia series of wires is not a great wire when there are so many loops. So I could able to advance pilot. You can see by this time, my antegrade wire is out. So, and we reached with pilot into the proximal vessel, but you can see at the proximal RCA it is subintimal. So I couldn't bring it back into true lumen. So that was the difficulty. So again, another failure. And then, I had to exchange my retrograde Corsair to Caravelle, so that I can go across the loop and escalate retrograde wire to Gaia series of wires and do subsequent thing. So we shifted to Caravelle. Caravelle could easily go through the loop, and then I switched to Gaia 2 wire, and now you can see this. By then my antegrade access is gone, and I was not able to deliver wire into RCA antegradely. So I had to take my retrograde wire into proximal RCA, and then you can see we gave a bend in almost like a ampliturization of JR, just to send retrograde wire coaxially into the guide. So that's how we sent it to antegrade guide, and then we anchored the wire, trapped the wire in the antegrade guide, but again stuck because of Caravelle. Caravelle was not advancing across the CTO. So that's when the retrograde wire, which was in antegrade guide, looped in aorta, and we were not able to again retain the position. So this is the next failure I had. And then, as I'm not able to bring retrograde wire, antegrade wire into RCA, so I had to snare retrograde wire. You can see I'm snaring retrograde wire with a gooseneck snare. And then, we pre-dilated. We exchanged to RG wire, pre-dilated. So this is injection only to see, not really to see the distal vessel, because we have really did a traumatic retrograde wiring. We know that there are some dissection flaps. So yeah, we dilated, and subsequently we did an IVUS. This is IVUS. You can see there is a clear multiple lumens seen in proximal RCA. You can see at 5 o'clock as well as 10 o'clock, but the final wire is in the true lumen. So my IVUS catheter is in true lumen. So the multiple lumens are created by retrograde, wire escalation. You can see here the flap where actually the wire came into true lumen. And this is the ostium of right coronary artery, which is quite clear. So, which says, I can end my stent little beyond the ostium. So then we stunted with 3 by 38 millimeter stent. And you can see at the end of stunting what exactly IVUS shows. You can see at the proximal end of the stent, still the true lumen and false lumen are still there. And in fact, the false lumen is actually compromising the true lumen too. So this is what I missed by fluoroscopic positioning. So then I had to put another stent covering up to ostium. And then removal of retrograde gear. For that, we used a kissing microcatheter technique. So advanced 2 microcatheters, antegrade and retrograde. And you can see this is very important because this RCA has a huge loop. If I lose an antegrade wire, sending antegrade wire back into right coronary artery is very difficult. So it's better to put a microcatheter distally before you pull out and everything. So you can see we checked septal, there is no septal injury as such. Yeah, and again, we checked through the RCA microcatheter, there is a mild septal injury, but that's okay, usually it won't progress. So, and we waited for 5-10 minutes and rechecked, it was not expanding, so we thought it's safe to leave it. And then we checked IVUS of stent, through which we went retrogradely and optimized expansion of LED stent. And this is the final result. And this is where we started, and this is a final result. So, and this is a final IVUS where we achieved good lumen areas. You can see 4.3 is the distal reference, and 6.4, 9.7 is almost close to the ostium of right coronary artery. To conclude, CTO needs persistence and perseverance. Every step is chosen keeping your successive step in mind, so that shouldn't spoil your next step. Septal collaterals can be connected to RV branch, and these are not good for retrograde maneuvering. Snaring can bail out in lack of antegrade access situations like this case. Thank you.